Hello, everyone, and welcome to our monthly webinar series. Today, we're talking all about cesarean birth. We're talking about the process of cesarean birth. We're talking about the options that many people don't even realize exist with cesarean birth, and we're talking about the healing process from cesarean birth. So today's webinar is not a discussion about when cesareans are necessary, when they're not necessary, how to know the difference, when is it a gray area. We're not talking about that. It is also not going to be a discussion about the kind of cesarean birth within the realm of public health. We're not talking about that either. We're just simply talking about what does cesarean birth look like? How can we make a process that feels very kind of surgical and sterile, feel a little more family friendly and gentle for both the parent and the baby? And how can we either be well supported in our own healing process from cesarean, or if you're a support person or a birth worker joining me today, how can you better support and inform your clients about what the process of healing looks like? So that's what we're focusing on today. And I'm really, really excited to share this information with you, because I think sometimes when people are looking for information like this about cesarean birth, it often gets muddled by the discussion of our extremely high rate of cesarean birth in this country. And I don't want to do that today. I really just want to focus on the education aspect of it, so that if somebody knows that a cesarean is the best way for them to move forward with their birth, or if somebody makes the decision during a laboring experience to have a cesarean birth, or if the factors kind of line up for that to be the safest way to move forward, I want people to have real, usable information without judgment, without bias. And that's what we're doing here today. So I'm so excited to have everybody joining. And we have people from all over the world joining, which is so exciting, and one of the most awesome things about being able to do stuff virtually. So let me just give you a little spiel about me and also about the webinar series that I do, and then we will dive into today's content. So my name is Brittany Sharp McCollum. I own Blossoming Belly's Holistic Birth Services based out of the greater Philadelphia, Pennsylvania area in the United States. The cesarean process that we're talking about today is very typical and kind of conventional for how things are done in the area that I serve as a doula. I'm a doula, I'm a childbirth educator. There may be some variation from place to place, geographical location to geographical location. So, bear with me if I'm not completely up to date on those slight variations that might happen in different areas. So feel free to ask questions in the chat. And if I don't know the answer to any of those questions, I will definitely get back to you. Let's see. So as I mentioned, I'm a doula, I'm a childbirth educator, I'm a perinatal pelvic biomechanics educator, which basically means I teach expecting parents and train clinical and non-clinical providers on how to utilize effective movement during labor experiences. A lot of the webinars, if you've taken a look at the list of webinars that are previously recorded on my website, a lot of them do kind of deal with pelvic dynamics and biomechanics and utilizing movement in medicated and unmedicated births. But I also teach general childbirth education, as well as classes and workshops on home birth, on VBAC, and then consults, private consults as well, on topics ranging from choosing the appropriate care provider, communication in labor, and cesarean birth, as well as other things too. So I've been doing this work for over 15 years. I teach in-person classes in South Philadelphia, and then I also teach virtual classes that are live. And then I have a whole bunch of self-paced courses that are comprehensive childbirth education, and then also 101 courses, which are taking just one specific topic like lactation or comfort techniques and putting them into a 1-hour self-paced course that people can access. So lots of good resources on the website. You'll also find that there's a whole bunch of free webinars. I think it's really important to make information that's usable also accessible. And so I generally every 2 to 3 months or so, I'll offer a free webinar just like this one. And we have free webinars on lots of different topics, topics including the pushing phase of labor, the induction process of labor, prenatal nutrition, pregnancy Q&A, postpartum Q&A, creating a birth plan, all sorts of free stuff on there. So and storing and pumping milk after birth. So please, please, please take advantage of all of those resources. They are free and accessible to anyone, anywhere. So if you wanted to share that information with clients, or if you're pregnant yourself or have friends that are pregnant, please feel free to share all those free resources. I think it's really important, again, for people to have information that is easily accessible and also really helpful in, building their confidence for birth. let's see. So that's my goal in providing this information, and pretty much everything that I do is helping people feel more prepared, more confident in approaching their birth experiences, and also for them to feel more actively involved in the decision making. And that really begins with understanding what the process looks like, whether we're talking about the process of labor or the process of surgical birth. And also we really want to understand what the options are, because when we understand our options, we can have better communication with our providers. We can be a part of that decision making. And what the research tells us is that when people feel like they're part of the decision-making process during their births, they come out of the experience feeling more positive. And that's the goal, to come out of your birth, no matter how your birth unfolds, feeling like you did something totally awesome. Then that can translate into a potentially easier shift into this new identity in your postpartum, this new identity as a parent, or a parent again if you're somebody who's already given birth. And I think, any good solid foundation we can get to help ease that transition in parenthood is really, really important. So that's what we're doing today. A couple logistical things. If you have questions, which I love when people have questions because it makes me feel like you're as involved and excited about this information as I am. Please put your questions in the chat. What I found with the webinars, because we have a limited amount of time, is that it's really easiest to put questions in the chat and have me address them at the end, only because oftentimes the questions that come up are things that I am actually going to cover down the road. So I think for the sake of everyone feeling like they're gathering information in a cohesive way, it's streamlined if I kind of share what I plan to share and then go through some questions afterwards. But put them in the chat at any point, and then at the end of our webinar, I'll go through and see what I haven't answered and spend a couple minutes answering those questions that you have. As I mentioned before too, this is recorded, so everyone will get access to the recording, anyone who is pre-registered. So even though you're here joining me today, the recording will be sent out to you in an email either later today or tomorrow. All right, so let's go ahead and get started. I do have slides, which, slides, I don't know. I don't love slides, but in this format, I think it's really helpful. Especially what you're going to find today is that this is really information heavy. I tried to make it less, not less information heavy, but a little less overwhelming with the slides. But I just feel like it's really important for people to be able to read the step-by-step process just as much as it is to hear me talk about it. So I do actually have things like really written out, which you can decide if you want to read it, you can decide if you want to just listen, whatever you want to do there is totally fine. But some of my slides are a bit wordy here, so I apologize for that. One other thing that I just want to mention is that in most of the webinars that I do that are related to pelvic dynamics, we incorporate a lot of movement. And I'm a big fan of incorporating movement into any sort of workshops that I'm doing. So although we won't move a whole lot today, we might get up and do some sort of movement or breath related thing. We'll see where our day takes us. All right, so cesarean birth, the process, the options, and the healing. That's what we're talking about today. So please remember that this information is provided for the purposes of education only. I'm not in a position to diagnose anything. We're not debating here whether a cesarean is necessary or not necessary. What we're really doing here is sharing information. And please utilize this information within the scope of your own role in birth, whether that is you're the person giving birth and preparing for your experience, or if you're a professional, particularly a professional, make sure we're using this within the scope of our practice. Please also remember that you have the right to be involved as an expecting parent. You have the right to be involved in every single aspect of your care. You have the right to consent, to refuse, to delay anything that is being presented to you. That is your legal right in the United States, and it is also recognized as a basic human right. So please make sure you keep that in mind too. And just an FYI, if you're like, oh, that's interesting, I wasn't really fully aware of that. Next month, January. Geez, January's almost here. Next month in January, I will be doing another webinar. This one's $15 though, and it's all about communication and advocacy during prenatal care. So if you're interested in joining me for that, you're welcome to. The registration is on the website for that. All right. Also, one other thing, I totally don't mind if you take screenshots today, but I just ask that you use them for your own personal use. If you do take something that is, that has other people in it, like if somebody's video is on, please don't share that obviously with anybody. But if you wanted to take like a screenshot here or there and post it on social media, I'm totally okay with that. I just ask you don't post the entire presentation on social media. All right, let's move on. Let's take a look at what our objectives are for today. So first, we want to understand the step-by-step process of conventional cesarean birth. I think because cesarean birth happens so commonly in this country, in the United States, we have about a 32% cesarean rate. Because it happens so commonly, I think it's one of those terms that's often just thrown around, and there's kind of this like expectation that, yeah, you'll just know what I'm talking about. But when it comes down to it, I don't think most people, even those who experience cesarean birth, actually understand the step-by-step process. So it is really important, I think, if you are planning for a cesarean birth or open to a cesarean birth, or potentially possibly down the road having to shift plans to have a cesarean birth, it's really helpful to understand step-by-step what happens in that process. So that's what we're going to go over first. Then we're going to explore the potential options that are available to make the process more gentle or family-friendly. This might be another term that you've heard recently, gentle cesarean birth. Sometimes it's also referred to as family-friendly cesarean birth, and sometimes it's referred to as maternal-assisted cesarean birth. So those are all basically the same thing. They kind of make the process a little bit more of an easier transition for both the baby and the parent. So we'll look at some of the options that may, depending on circumstances, be available to make a cesarean birth feel a little less of a sterile procedure and more like a transitional birthing experience. And then we're going to recognize the important aspects of postpartum healing after cesarean. Geez, in this country, I don't know, I'm sure that you all realize this. In the United States, postpartum care is awful. Awful, awful, awful. When people go through the laboring experience or a cesarean birth, either way, they have one follow-up visit with their clinical care provider somewhere around 6 weeks after birth. That's it. That is crazy. Anytime somebody has had any sort of major surgery or any sort of physical process happen to them that is considered in any way clinical, there's going to be far more follow-up care. For example, if somebody had knee replacement, they're going to physical therapy, they're getting frequent doctor follow-ups. None of that's happening after somebody gives birth. And yes, if we're talking about a vaginal birth, that is a physiological process. It's very similar to respiration, digestion, but your body has still changed tremendously and does require some follow-up care. If somebody's birthing by cesarean, that's major abdominal surgery. And to expect only one postpartum visit around 6 weeks is crazy. And no physical therapy after vaginal birth or cesarean birth, nuts, totally nuts, because physical therapy, pelvic floor physical therapy, is such an extremely important part of care after birth, regardless of how somebody gives birth. So important. And I do see somebody wrote in the chat that they did have more follow-up care. Somebody said they had a 2-week and 6-week post-cesarean appointment. That's better, right? That's better. That's amazing. I'm glad you got that additional appointment. A lot of people don't. It's not often part of postpartum care. So yeah. Yes, and we have another comment in the chat, and that's if birthers even get to their 6-week appointments. Absolutely. By the time 6 weeks rolls around, most people are starting to feel a little bit better after birth, starting to get back into whatever is going on. Some people are even returning to work, which, again, crazy, right? And so if they even make it to their postpartum appointment. Anyway, okay, I gotta stop checking the chat because otherwise I feel like we could just have a discussion all day, which would also be really, really beneficial, but maybe we'll have to plan that for another morning. Okay. So let's come back here and talk about these objectives. So here's my really, really wordy slides, right? But I do want to point out that although these are very wordy, you can choose to either listen to me or you can choose to read it. And I know with webinars, oftentimes people are doing something else and listening in the background. So totally okay if you want to do that. I will run through it verbally step by step too. I do have every step listed out here so specifically though, because again, I think that there's this assumption that cesarean birth, we know what that is, but do we really understand step by step what that entails? So that's why I've kind of been really thorough here. First, I do want to point out that cesarean surgery is the most commonly performed surgery in the United States. This means it is a very, very, very safe type of surgery. So the procedure itself is extremely safe. There are risks, of course, just like there are risks with any sort of major surgery, but the cesarean procedure is actually very, very safe. It is the most commonly performed surgery in the United States. All right, so when it's decided that a cesarean is going to happen, whether this is a planned cesarean or whether this is a cesarean that's happening during a laboring process, epidural anesthesia is given. This is a continuous drip of medication administered into the lower back, and it provides excellent pain relief. Now, if somebody is laboring already and they have an epidural in place, the epidural medication will be increased. If somebody is not laboring, the cesarean birth is scheduled, or if they're laboring without pain medication, it will often be a spinal that's given instead of an epidural. They're both regional anesthesia, and we actually have a webinar all about the options for regional anesthesia, so if you do want to dive into that, you totally can. But a spinal is a one-time dose of medication delivered into the membrane that surrounds the spinal cord, providing excellent pain relief that lasts for about 1.5 to 2 hours. So if someone does not have an epidural hooked up already, it's often a spinal that will be given because it's a one-time dose of medication. If somebody already has an epidural, though, the epidural medication would be increased. And for some providers, they do give an epidural instead of a spinal. So there are some variations there in terms of who your provider is and what their typical practice is. This is regional anesthesia, though, which means that you are awake and fully alert during the process, but you generally can't feel anything from about the rib cage down. There are some situations where general anesthesia is given, and this is only in about 5% of cesarean births. So general anesthesia is not commonly used for cesarean birth. When general anesthesia is given, it's circumstances like low platelet count, which would mean that there's a greater risk for bleeding if an epidural or spinal is administered, or a situation where things become emergent so quickly that there is no time to administer the epidural or spinal. The more common reason is low platelet count, not actual emergencies that arise out of nowhere, and the entire likelihood of needing general anesthesia is actually quite low. But with general anesthesia, things do shift a little bit because you're not awake, you're not alert throughout the process, you're basically quote unquote asleep throughout the process, and when general anesthesia is administered, support people are not allowed in the OR. The term OR refers to operating room, which is where a cesarean birth takes place. If you had general anesthesia for a cesarean, you would not be able to have a support person there with you in the OR, but they would be able to be with you in recovery. If you are not having general anesthesia, which is the way that most people give birth, most people give birth by cesarean with epidural or spinal medication, then it is typical to allow one support person in the OR while you're having the baby. It is really important to point out that COVID protocols have definitely changed that, although most hospitals are shifting their COVID protocols to go back to kind of favoring more support. But that's a great question to ask of your provider. Are there any COVID protocols in place that would prevent me from having a support person in the OR during a cesarean? So really important question to ask so that you can, again, better fully understand what that process might look like. All right, so pain medication is administered, and then the vital signs are monitored to make sure that you're handling the pain medication okay, to make sure that everybody's stable for moving forward. An oxygen mask may also be placed over the nose and mouth. Not always. That's, again, just depending on the oxygenation level. Now, if you're having a support person in the OR with you, the support person is going to be either in like laboring room if you were laboring, or outside of the OR, and they're going to put on scrubs. And so the support person is fully covered in scrubs from a little, hat all the way down to covering their shoes as well. Again, typically one support person is allowed in the OR. Unless general anesthesia has been given, then no one is allowed in the OR as a support. But sometimes there are exceptions made to allow for two support people to be in the OR. Oftentimes that would be a primary support person like a partner or a friend or a family member, and a doula. So if you have a doula there with you for your birth, it is possible to have your doula allowed in the OR. It is really dependent upon the OB who is doing the cesarean birth and the anesthesiologist who is monitoring the pain medication and administering the pain medication. It is not a given that two people would be allowed in. Just because you have a doula does not mean that the doula would be allowed in. It is typically one support person, which could be a doula or could be partner, family member, friend, And then if an exception is made, they may allow for an additional support person being the doula if the first person is not the doula. So again, great question to ask. If you're at a prenatal visit, you could always say to your provider, I plan on having a doula with me for my birth. If I'm having a cesarean, is it possible to have both my doula and my other support person in the room with me? Great question to ask prenatally. Now, while the birth support person is putting on the scrubs and waiting possibly in the laboring room, or again, if no labor has been happening, if it's a planned cesarean, they're waiting in more of like a kind of a check-in room. Then the person giving birth is brought into the OR. The OR is very cold. I know that seems kind of weird to point that out, but just be aware of that. The OR is cold. It's a very sterile environment, and it's cold in the OR. One of the things you can do, though, as we'll talk about later, is request that the temperature be raised in the OR. Anyway, I want to talk for a moment about this, how the person giving birth goes to the OR and the support person does not go at the same time. I think this is really important to point out because sometimes, especially if we have a laboring experience that has led to a cesarean birth, there's oftentimes when the decision is made to move forward with cesarean birth, there's a lot of emotion surrounding that experience. And then all of a sudden, because it's decided that a cesarean is happening, there's a lot of people coming into the room, not necessarily rushing into the room, but a lot of people coming into the room. And then the steps for creating a sterile field are done, and which we'll talk more about in a moment. And then signatures are given on paper, and it's kind of like this, feels like a very kind of chaotic rush to get everything moving into the OR. And so there's all this like energy and all this emotion. And then the person who's pregnant goes into the OR and the support person is left in that laboring space. And they're there in their scrubs by themselves, waiting for somebody to come and get them and bring them into the OR. And it is an extremely odd feeling to have all of this kind of energy. And the fact that you're like that person, let's say it's a partner, they're about to meet their baby, right? And then it's like, okay, the person you care about more than anyone in the world has been whisked off into the OR. And now here you are waiting, hoping that you're going to be remembered, like that, hoping that the nurse is going to remember to come get you. I know as a doula who's been in a situation like that many times with clients, I know it's a really, really challenging emotional space for partners particularly to be in. So I just want to put this out there for anyone who might be a partner here today or anyone who wants to share this with their partner or any support person. The nurse will not forget about the support person. The nurse, once the pregnant person's in the OR and totally ready to go, then the nurse will come back and get the support person. They will not forget. And I know it feels like they're going to forget, and it feels like very odd to be standing there for about 10 minutes or so, which is typically about how long it is, with nobody like even in the room with you. But it's really, really important for support people to know that the nurse will come back and get them. Again, it's a very kind of anxiety-ridden situation oftentimes for support people, and it's really, really important for them to know that they will not be forgotten, that the nurse will come back and get them. All right, so I just like to make sure that everybody realizes that. All right, let's move on with our process here so that we can, again, better understand exactly what's happening. So I mentioned that the support person gets totally prepped for the cesarean birth, right? And so we can see that listed here in this first little bullet point up here. So the area is washed. The area is the area where the incision is going to be made is washed with betadine, which is like a very kind of, it's almost like a reddish brownish color liquid that creates a sterile field. Any hair is also shaved off that might be just above the pubic bone. And then a catheter is placed in the bladder, and this is going to keep the bladder empty during the cesarean. So the bladder lies in front of the uterus, and if the bladder is full, then it is going to affect the ability to access the uterus. So the bladder does need to stay empty. And then in the OR, sterile drapes are placed over the abdomen, so that when the person is lying down, if they kind of lifted their head up to look at their feet or look at their belly, because who can see their feet when they're really pregnant, there's going to be a sterile drape there. Again, right about the level of the rib cage so that the person is not able to see the incision or see the baby coming out. Again, that's an option that we could request that the drape be taken down, but we'll get to that later on. After that person is fully prepped, drape is up, everybody's ready to go, the birth support person is brought into the OR. They are expected to stand or sit, typically sit. They're expected to sit by the pregnant person's head. And they are able to stand up and look over the sterile drapes if they want to, but they are expected to sit on a stool in case the experience is a little too much for them. We don't want anybody getting wobbly on their feet. Let me take a moment here now to talk about how full the operating room is. There's a lot of people in that space. So there's the person giving birth, and then there's a support person, possibly another support person like a doula. And then there is also going to be a nurse for the person birthing, a nurse for the baby. Generally, in my experience, at least 2 nurses assisting the obstetrician, not typically 1 nurse, although I guess that's possible. But in my experience, it's always been 2 nurses assisting the obstetrician. If a midwife was providing care up until this point, a midwife may also be present. But midwives do not do the actual procedure. OBs do the procedure. If you were receiving care from a midwife, you can still have a cesarean birth. It will be an OB that does the cesarean, though. But the midwife is typically in the room while the cesarean is happening. There's also an anesthesiologist, and there's a nurse for the anesthesiologist as well, which I don't think I've got listed there. There's a nurse for the anesthesiologist, and there's a pediatrician in the room as well. And then there may be a nurse assisting the pediatrician in addition to a nurse specifically there for the baby. Now, students can also be present. So that's a lot of people, right? Like that's like give or take 10 people in the room. Now, we could also have students present that are observing the process. Wow, that's a lot. That's a lot more people in the room. That's a lot more potential for conversation, chatter, right? That's a lot more energy being brought into the room. And so it's really important to know that it is your legal right in the United States to decide if you are or are not comfortable having students present in any aspect of your prenatal care, your birth care, or your postpartum care. I just want to point out a couple things. Students do have to be introduced as students. Like you will be told that they are students. You are not typically given the option of saying, oh, I don't want them to be here, but you always have that option. So just know that you can say, great, wonderful, glad they're here, or you can say, nope, not interested in having students present. Now, typically students will be part of the actual process, meaning that they may do things that the OB might be doing. You can also decide how involved you'd like students to be. You can state that you're comfortable having students present, but you don't want them doing anything clinical. Or again, you can state that they can do everything that they would normally do. So you can decide how involved or uninvolved you'd like students to be. Again, it's not going to be brought to you as a decision, but know that you do actually have that legal right to decide whether or not students can be involved or not in your birth. All right, so once everybody's in place, a 4 to 6 inch incision is made just above the pubic bone. This is an incision made in the skin, and this is the incision through which the baby will come. However, the baby's not just underneath the skin there, right? So the baby is underneath the skin, but the baby's also underneath the abdominal muscles. The uterus is underneath the bladder, and then the baby is within the uterus within the amniotic sac. So there's a lot of layers here that do need to be kind of moved through in order to be able to pull the baby out. So the abdominal muscles are spread apart. The bladder may be pushed aside, or sometimes the bladder's actually, and you bear with me, the bladder is sometimes lifted out of the body and placed on the abdomen. I should have mentioned this in the beginning. We're talking about surgical birth here. So there is going to be some things that might make you cringe a little bit. There might be some potential triggering issues coming up. So please feel free to log off if you need a minute. That is completely okay. Or you can mute me. I don't know if you can do that. If you're able to do that, you can do that. Do what you need to kind of let yourself have that space that you need. You can always come back and watch the recording. Don't feel like you have to sit through anything that's making you uncomfortable if you need some time to process. So after the abdominal muscles are spread and the bladder is moved aside, an incision is made in the low part of the uterine wall. This is called a low transverse incision, or a bikini cut. This is the most common incision made for cesarean birth. If somebody has been laboring, the lower portion of the uterus is typically thinned out, so it's a very easy cut through that uterine wall. If the person has not been laboring, the uterine muscle is much thicker there, and the cut, again, it's still in the same place, but it's more muscle that's being cut through. A classical incision could also potentially be made, and we'll talk about what makes that decision in just a moment. And then also somebody could have a incision that's more of a T shape or a J shape, although this is very, very rare. A classical incision would be made higher up in the uterus, and it's a vertical cut, so a cut down, whereas the bikini cut is a transverse cut or a cut side to side. Again, the low transverse incision is what's most common, but it is possible to have a classical or a J or a T incision. There are a couple downsides with the classical incision, the J incision, the T incision. This is typically being cut through the thicker part of the uterus, the part of the uterus that does not thin during the laboring process. So there is the potential for more scar tissue development, and scar tissue development can lead to problems in subsequent pregnancies. We also do see a higher risk of uterine rupture if there's been a classical J or T incision made as compared to a transverse, low transverse incision. So you can actually see here what some of the research says about risk of uterine rupture. Uterine rupture is when that uterine muscle actually tears, and that would be something that we're talking about potentially happening in subsequent pregnancies or births, not this specific incidence. After the uterus heals, someone becomes pregnant again, then we see an increased risk of uterine rupture in that next birth experience. But I do want to point out here that, so we're using a term called VBAC, vaginal birth after cesarean, for somebody who's had a previous cesarean is now going on to have a vaginal birth. That's when we're talking about that risk for uterine rupture, which is often a reason why people are told they should not have a vaginal birth after cesarean. In reality, the research actually supports vaginal birth after cesarean for up to about 70% of people who've had a previous cesarean birth, which means the majority of people who've had a cesarean birth in the past can go on to have a vaginal birth. We see that with a low transverse incision, the risk of uterine rupture is less than 1%. It's about 0.4%, versus the rate of uterine rupture with a classical incision, which is roughly about 2%. It's really, really difficult to find a care provider who would support a VBAC with a classical incision. I mean, if you think about it, the risk is still low. There's a 98% chance that everything would be fine, but because that risk jumps so much from the low transverse incision, it's a liability that most providers are not comfortable taking on. It's actually it can be somewhat challenging to find a provider for somebody who's had a low transverse incision and wants to have a VBAC as well. And really, finding a VBAC provider who truly supports vaginal birth after cesarean is one of the greatest risks of having the first cesarean. If you've had a cesarean and you want to go on to have a vaginal birth in the future, it's harder to find a provider who's truly supportive of that vaginal birth. That's something that, definitely it helps to be connected to local providers in your area. So if anybody has specific questions or needs recommendations, you're welcome to send me an email. And if I'm not in your geographical location, I can reach out to colleagues that I know that might be near you and can help provide you with information if you are interested in that. All right, so that was a lot. So I just want to kind of recap what we just said. The low transverse incision, which is an incision made across the body just above the pubic bones. It's about 4 to 6 inches long. That is the most common incision made, and that incision has the lowest risk of uterine rupture in future births. A classical T or J incision are other options. They're made higher in the uterus, and they have a higher risk of uterine rupture, and it's very difficult to find providers that will support a future vaginal birth with that type of incision. Now, why might a provider choose to go with a classical or a T or a J incision? The most common reason is where the placenta is located. So the placenta is an external organ of the baby's, and it is implanted in the uterine lining. Most of the time, as pregnancy progresses, the placenta appears to migrate upward. It's actually just the tissue stretching, so the placenta is not moving, but the placenta tends to be higher in the uterus, in the front, in the back, and the side. Doesn't really matter where the placenta is. But if the placenta is low-lying, covering over the cervix, which would be an actually absolute reason for a cesarean birth, or if the placenta is just lower in the uterus, then there is a risk when the incision is made of actually creating excessive bleeding by cutting into that area where the placenta is attached or cutting into the placenta itself. And this could be extremely dangerous for the parent and the baby. So in those situations where there's a concern about where the placenta is lying, that would be a reason for a classical J or T incision. So I want to share with you a little animation that shows the incisions being made. This is an animation. It's not somebody actually going through a cesarean birth, but it is somewhat realistic. And so it can be a little bit jarring to watch. It's not very long. It's about like 10-15 seconds. But I just want to give you that little kind of warning that I'm going to show this now. You can watch, you don't have to watch, whatever you feel comfortable with. And this is shared through Instagram. So before we start. Okay, sometimes it starts very quickly. So here we can see the abdomen and we can see the scalpel that's being used to create that incision. So we'll watch this now. Again, it's not long, but if you have any questions, of course, you're welcome to put them in the chat. All right, so a little quick, but also sometimes maybe a little bit jarring to watch. So I just want to give you a moment. If you have questions about that, you're welcome to put them in the chat. But I do think that that's a really helpful animation to see. It's not perfect. You know, it doesn't obviously show every single step of the process. It doesn't show amniotic fluid being suctioned out. It doesn't show cauterization of the blood vessels. But it does kind of focus on the incision and the suturing that happens afterwards, which we'll talk about the suturing debate, the great suturing debate in just a minute. But if you have questions, please feel free to post them in the chat. And then I will answer them after towards the end of our webinar. Sorry. All right. So let's move on. Here's the rest of our process. So as I said, that animation does not show amniotic fluid being suctioned out, but of course, as an incision is made in the amniotic sac, there's amniotic fluid in there, the baby's floating around in, and so that amniotic fluid does get suctioned out. Blood vessels are cauterized to prevent excessive bleeding, and you can hear that. You can hear the suctioning, and you can smell the cauterization. What it smells like is kind of like that smell of like hair burning. So it kind of has like an acrid odor. That's what's happening there. So if you're hearing suctioning and you're smelling a weird smell, that's normal. So don't be concerned. I think, again, if people don't know that, it can be very, very jarring to have these other kind of smells and sounds during the process. So I think really important to know that. The person who's experiencing birth should not be feeling sharp shooting pain with any of these incisions. What they do often feel is more of a tugging sensation, which is a very odd, weird sensation, but not sharp shooting pain. But that tugging can lead to nausea. And so the nurse that's there to provide support to the person birthing will have a little bin there, a little basin in case you do need to vomit. The baby is pulled from the uterus by the head and neck first. If the baby is low in the pelvis because of laboring has happened, the baby may need to be pulled up out of the pelvis and then pulled out through the incision. If the baby is in a breech position, presenting with their butt or their feet first, then it's the baby's bottom that's actually pulled out first. The umbilical cord is then cut like we saw in that video. So a clamp is placed on either side, the parent side and the baby side, and the cord is cut in between. The baby is immediately brought to the warming area in your conventional cesarean birth for evaluation. And this is evaluation by the nurse and the pediatrician. One thing that people are not often told, the support person can go right over there to the baby. Unless somebody tells you that they need you to move out of the way, you can go to the baby, talk to the baby, touch the baby. That might be the only thing that's would be the only thing that's familiar to the baby in those first few moments after birth. So it could ease the release of stress hormones in the baby's body. This entire process from the very start that we mentioned, getting the person laboring, the person birthing all prepped up to the actual birth of the baby is usually about 5 to 10 minutes. So that process of the person being in the OR, getting the betadine solution on their lower abdomen, and then moving to that actual birth of the baby is 5 to 10 minutes. It's very, very quick. But it's the suturing time afterwards that often takes a while. This could take sometimes 20 minutes, which would be pretty efficient, sometimes even longer, 40, 45 minutes. Now, here we are with the baby's been born, baby's on the warmer. Now we have the suturing process. So Pitocin is added to the person's IV, and this is going to help encourage the uterus to continue clamping down. Pitocin is added to the IV, the placenta is manually removed, and then the Pitocin starts running after the incision is completed. So Pitocin is added to the IV, but not yet running. The placenta is manually removed, as we did see in this video, so kind of scooped out of the uterus. You can keep your placenta. It's actually your baby's placenta, but you have every right to keep the placenta. So you can request that if that's something that you're interested in. Suturing of the uterus can take place with the uterus still inside the abdominal cavity, but sometimes the uterus is actually removed from the body in order to do that suturing. And suturing could be either what we call single layer or double layer, which we'll take a look at both of those in just a minute. After suturing takes place, the uterus is kind of nestled back in, the bladder is then put back in or kind of moved back into the correct area, and then the skin is closed typically with dissolvable sutures. Staples used to be used. They're not used as commonly in the United States. Staples do have to be removed, so the person has to go back to have those staples removed around 2 to 3 weeks after having the cesarean, but most commonly dissolvable sutures are used now. After this process, the person is all cleaned up. They are wheeled into the recovery room, and they can be in the recovery room with their baby as long as everything is fine with the baby and with their support people. And this is more than just the one person that was in the OR, but if they have a partner and a doula there, then both of those support people can be in the recovery room. They're monitored in the recovery room for about 1 to 2 hours after birth, and then they are typically moved to the postpartum room. Monitoring in the recovery room may be longer if there are any complications that have occurred, or if there are any complications occurring in that postpartum period, but typically it's about 2 hours or so that somebody spends in the recovery room, and then they're brought to their postpartum room. All right, so that's a lot. So take a moment to kind of digest all of that information, and we're going to move on and talk about suturing options. One of the great things about having access to this recording is that if you need a few more minutes to process, you can totally go back and you can rewatch this, or for those of you watching the recording, you can pause here if you need a minute to be like, whew, that's a lot. All right, so I want to talk about suturing. Our time flies by. Oh my gosh, I can't believe we've already been here for 40 minutes together. So I want to talk about the suturing options that are available. Now, here's the thing. Oftentimes, providers will do the type of suturing that they feel is best. And when we're talking about suturing, we're discussing actual suturing of the uterine muscle here. We're not talking about the suturing of the skin. So providers will often do what they think is best and also what's most feasible given the circumstances of the birth. But we could say there are 2 options available. There's single layer or double layer suturing. Single layer suturing pulls together the cut edges of the uterus, and then smaller sutures are used in between those larger sutures to stop bleeding and pull together the unopposed edges. So it's like the edges are pulled together, and then there's additional little sutures made in between that's pulling together the skin that is, or not the skin, the muscle fiber that is not actually cut. That's single layer. I'm describing 2 sutures, but that's single layer suturing. Research does show that with single layer suturing, there's fewer postpartum complications, lesser risk of inflammation, infection, endometritis, and hemorrhage. So we do see benefit to single layer suturing, lesser risk of postpartum complication. Also, we have research that found no increase in placental problems with single layer suturing as compared to double layer suturing. So there is no increased risk of future placental problems in future pregnancies with single layer suturing compared with double layer suturing. I do want to point out, though, that with every cesarean birth that occurs, there is greater risk, particularly of placental issues, which means if somebody has one cesarean birth and then has another baby and another baby and another baby, they have a low risk of placental issues happening in these future pregnancies. But if somebody has had 2 cesareans, 3 cesareans, and wants to have more babies after that point, there is greater risk with each of the previous cesareans of having placental problems in future pregnancies. So that's just something important to know about since we're talking about placental problems. But what these studies looked at specifically is not the risk of placental problems with future pregnancies after multiple cesarean births. I know this is a lot. What this research looked at is the risk of placental problems with single versus double layer suturing. All right, I appreciate you bearing with me. That's a lot of information. The other option besides single layer suturing would be double layer suturing. Double layer suturing pulls together the cut edges of the uterus and then pulls together, like we did with the single layer, those little bits of unopposed tissue in between, and then a second layer of tissue is pulled together with more sutures. So this is double layer suturing. So we have the same thing as we have with single layer suturing, but then we have an additional layer of uncut tissue being pulled together. Double layer suturing theoretically would create a potentially a stronger stronger scar, I guess, at the where the incision has been made. However, what the research actually shows us is that there's really not a significant difference in uterine rupture rate with single versus double layer suturing. Only 1 out of 11 studies found a lesser rate of uterine rupture in subsequent births with double layer closure as compared to single layer. So the evidence is really considered inconclusive, meaning that the evidence does not clearly point to double layer suturing decreasing the risk of uterine rupture. And when we do see with single layer suturing that there is other benefits, single layer suturing has a lesser risk of postpartum complication, many providers do go towards or lean towards doing single layer suturing as opposed to double layer suturing. But sometimes people feel like they want to have that double layer suturing because it may help to ensure that that scar area is particularly healed very well. However, again, the research is inconclusive as to whether double layer suturing would decrease the risk of uterine rupture. I do want to point out a few things. When it comes to suturing, it's best to have a conversation with the provider in advance. This is not something that you'd have a discussion about when you're laying on the OR table and they're about to do the first incision. This is something that's really important to talk about with providers in advance. So again, more information to talk about prenatally. If I have a cesarean birth, do you typically do single layer or double layer suturing, and what circumstances would warrant one or the other? Remember, one of the most important things with prenatal communication, with communication in general, I think, with providers, is asking questions that are open-ended. So you could say, do you have a preference for single or double layer suturing? But the more important question would be, what are the circumstances that would lead you to do double layer versus single layer? That's what you want to really find out. So single layer suturing, as we mentioned, is far more commonly done. And this is particularly true with low transverse incisions, particularly after somebody's been laboring, because that uterine tissue thins out at the bottom. And that means that it's much harder to actually pull together that uncut tissue with the double layer suturing because that uterine tissue is so thinned out and stretched. So single layer suturing is the most common suturing that providers do. And this is far more common with a low transverse incision than we would find with a classical or T or J incision too. Now, if you're familiar with Ida Mae Gaskin, who is a midwife, she is fairly well known and also has written many books. One of her books, Ida Mae's Guide to Childbirth, has a really kind of in-depth chapter about suturing. She believes that double layer suturing is really, really important because she believes that it will strengthen that scar area. ICANN, which is the International Cesarean Awareness Network, has a really good resource on their website called The Suture Debate, and they share that single layer suturing seems sufficient for not significantly increasing the risk of uterine rupture. So not such a clear-cut answer, but definitely some points to consider there, and I would have that discussion with your care provider in advance, if possible, about what their thoughts are on the different options for suturing and what the circumstances are that would lead them to choose one over the other. All right, let's shift gears. Let's talk about how we can take that process that feels very kind of clinical and create more of a gentle process. So gentle cesarean birth, family-friendly cesarean birth, often termed maternal-assisted cesarean birth, basically means that we're incorporating some different factors that can make that process a little bit smoother, easier for both the parent and the baby. So this is a graphic that I created. You can find this on my Instagram account too. This is some reasons for gentle cesarean birth and some options you can request. I don't particularly want to read through every single one of these, but I do want to share 2 videos with you of maternal assisted cesareans, which is kind of cool to see. But I will just kind of share briefly a few things. As we kind of recognized with that cesarean process, and I know that was a lot of information, but it feels very, very, very clinical, right? And there are lots of aspects of it that are very much like, okay, baby is out, clamp and cut the cord, bring the baby to the warmer, very kind of disjointed, not necessarily honoring that like transformative experience of birth. So a gentle cesarean birth allows for a little bit more of that. So it encourages the parent and the baby to bond immediately. It eases that transition. It can reduce the release of stress hormones for both the parent and the baby. It keeps the parent and the baby as the focus. Gentle cesarean birth can actually reduce our perception of pain during the process and postpartum. It decreases the likelihood of a NICU stay for the baby. Having skin-to-skin contact right after birth, which is part of gentle cesarean birth, helps to stabilize the baby's blood sugar levels, stabilize the baby's breathing, stabilize the baby's heart rate, and stabilize the baby's body temperature. And this is a really great way to encourage nursing, allowing the baby to kind of tap into all of those instincts that come into play when the baby is right up on the parent. So some of the options that you can request to help get these great benefits of gentle cesarean birth would be walking into the OR on your own if you don't have pain medication already. You could request introductions from the assisting staff so that you actually know who the people are that are in the room with you. You could request that ECG leads be placed on your back rather than on your chest so that we don't have any wires getting in the way of skin-to-skin contact after birth. I am going to read through all these, even though I said I wasn't going to. We could request clear, sterile drapes as opposed to a drape that you can't see through. You could also request that the drape be dropped when the baby is born. We could play music in the room. We could lower the lighting in the room. We can also request minimal side conversation. We can, of course, have a say in the suturing that happens. Again, prenatally, that's really the time to have that discussion. You can request delayed cord clamping in gentle cesarean births. Not all of these things, or, delayed cord clamping specifically would be possible depending on the circumstances. But if we have healthy parent, healthy baby, delayed cord clamping is absolutely something that you could request. And the World Health Organization recommends it. The World Health Organization actually recommends delayed cord clamping, which they state as being at least 1 minute before clamping and cutting the umbilical cord in all births, vaginal or cesarean. You could also request immediate skin-to-skin contact, and you can request delaying of newborn procedures like the erythromycin eye ointment, vitamin K shot, etc. So here are a few reminders for non-clinical support. Request 2 support people. If you have a doula with you and you have your primary support person, request that they both be in the OR with you. Delay visitors because you've just had major abdominal surgery. It's a lot, and you're also trying to bond with your baby after birth. So delaying visitors can be a really great way to just help kind of ease those first few hours postpartum. Use hand massage to encourage touch during birth. So this is a great way for partners to kind of keep that physical contact. You can use essential oils to make the room smell a little less sterile. Talk to your baby, touch your baby. That could be the partner doing that. That could be the person birthing doing that. Ask questions along the way. If you're unsure about what's happening, or if you want the process discussed as it's happening, request that of your support people. And then positive language and affirmations, the same sort of things that you might use during a laboring experience to keep somebody positive and confident. You're going to use them during cesarean birth too. So I want to share 2 maternal assisted cesarean birth videos. So these are real videos. These are somewhat graphic. So just bear that in mind, but they're also, for the people who experience them, extremely healing experiences. So the first birth we're going to call Joe's calm and magical birth, and these are both shared with permission, just so you know, because that is how she described her birth. It was calm and magical. So this is shared from Dr. Natalie Elphinstone's Instagram account. Dr. Natalie Elphinstone is an OB in Australia who actually trains providers on doing maternal assisted cesarean births. So we'll watch this again. It is graphic, so just bear that in mind. And then we'll watch one other one too. All right, so let's start with this one. Oh wait, one sound here.
Shall I stay? Would it be a sin? Oh, falling in with you.
Oh my gosh, I should have told you to get tissues. When I was looking through maternal assisted cesarean births for this webinar, oh man, it's like, whew, it's beautiful. It's amazing. All right, I want to share with you one more maternal assisted cesarean. If you want to follow Dr. Natalie Elphinstone on Instagram, and you want your newsfeed to be filled with beautiful births that make you cry, you can totally go ahead and do that. And I want to share one more with you before we move on. And I know we're running short on time. I'm going to cover all the content that I plan to, even if it winds up taking us to 10:30 my time. So if you need to log off, please don't feel bad. I'm not going to be like, oh my gosh, everybody left. I want to make sure that we cover everything that I promised to cover in this webinar, and I think the process of cesarean took more time than I anticipated. So I will just keep going until I've covered everything I want to. If you want to hang out with me longer than that for that hour that I expected this to be, you're welcome to do that, but also don't feel pressured to. All right, so one more maternal assisted cesarean. So grab your tissues and we'll watch this person's experience.
Hero, baby. I can kiss away the pain. I will stand by you forever. You can take my breath away. Would you swear that you'll always be mine? Or would you lie? Would you run and hide? Am I in too deep? I lost my mind. I don't care, you're here tonight. I can be.
Oh my goodness. I started to cry on that one. All right, let's get ourselves back together. Okay, so we can see how incredible, a cesarean birth can be. I think that sometimes we think, again, it's surgical, it's sterile, it's like not necessarily what some people envision their birth to be, but it can be a beautiful, incredible experience, and you can advocate for that. And even if it doesn't happen the way that we just saw it, it can still be a beautiful, incredible experience. But it's, I think it's really important that we view cesareans as birth. This is birth. This is a transformative experience for the baby and for the parent. So, all right, let's start talking a little bit more about the healing process. So again, feel free to log off if you need to, because I know I've taken up almost our full hour already, but I'm going to stay on here and talk more and more and more. I'll just, cover what I have planned. But here is a really detailed list of what that physical recovery looks like in the first 12 to 72 hours. The first 2 hours, you are generally still getting pain medication from the epidural, if that's what you have had for pain relief. If you've had a spinal, then the spinal has worn off at this point, and you may be given intravenous medication, like narcotic medication for pain relief. There's often a lot of shakiness, some nausea, itchiness in your body from the narcotic component of the medication. So a lot of kind of weird discomfort that we don't necessarily associate with the discomfort of the incision, and that's typically happening in the first 2 hours. And this is where you're when you're in the recovery room, and then head to the postpartum room after this point. The next 10 to 12 hours, you're starting to feel that discomfort from the incision. So there's soreness in the incision area. Your body often feels very weak. You've gone through major abdominal surgery. Still some nausea might be present, especially if you are getting narcotic pain medication, which most people are having at this point. Usually it's going to be something like Percocet that's given. There may still be narcotic given through an IV at this point as well. Around 12 hours after birth, nurses will get you up and starting to move. However, if you have magnesium sulfate, which is given if somebody has elevated blood pressure or the diagnosis of preeclampsia, then it's going to be 24 hours on that magnesium after giving birth, and it's not until that 24-hour mark that you're going to be up and moving around, because magnesium can make you feel very woozy and very out of it. The first 10 to 12 hours after birth, there is very heavy vaginal bleeding, and this is due to the uterus going back down, beginning to kind of contract down to its pre-pregnancy size and shape. This would be a time where you could have a light meal. They would start out with very light foods just to make sure that you're handling it okay and not vomiting. And they're also going to encourage you to do deep breathing exercises. They'll give you a little contraption that you can breathe into. And this is to help reduce the risk of pneumonia from being reclined or semi-reclined for a long period of time. The next 12 to 24 hours look very, very similar, but you will get up to use the bathroom. The nurse will expect to get up with you, to be there with you, supporting you every time. You will be encouraged to move often, though, in your bed. You would be encouraged to roll your ankles, roll your arms, like just shift your legs around to help encourage that circulation, prevent excessive swelling. There is numbness or soreness at the incision site around the 12 to 24 hour mark. You do start to feel that discomfort of the actual incision even more so. The narcotic pain relief should help with that. But it is normal to feel some soreness at this point. The incision may be dark and kind of puffy, that's puffier than the surrounding skin. You're not necessarily seeing weeping or oozing from it, and it will be covered by a bandage. And the nurses will actually go over how to change that bandage with you. Around 24 to 72 hours for a lot of parents, this can be one of the most challenging points of cesarean recovery. There is often a lot of discomfort and bloating from the buildup of gas inside the body, which is common with any sort of major surgery. Not specific to cesarean. Gas gets trapped in the body. The only way to get that gas out is just to wait for time to pass and the gas will dissipate. But this can create a lot of extreme discomfort in the abdomen and even in the person's back. So this is again not often talked about part of cesarean birth that I think is really important. That discomfort that comes on within the first couple days after birth, and that extreme discomfort from the gas and the bloating. There is discomfort in the incision site at this point. Possibly narcotic pain relief would still be administered. Typically, people are sent home with a prescription for Percocet, which they may take for a couple days. Sometimes people take it for longer than that. Sometimes people just need prescription strength Motrin or Tylenol. Sometimes that can be enough. It depends on the individual person. It is also possible to have constipation. So on top of the surgery, you also may have constipation, which can be caused by disruption to your digestive system, but also could be caused by narcotic pain relief. Let's take and this is typically happening all in the hospital. For cesarean birth, you typically spend 3 nights in the hospital. The baby stays in the hospital with you, and then you go home after 3 nights. So once you get home, it's really important that you allow your body to rest and recover. I can't emphasize that enough. Sometimes people are a few days postpartum and they're like, I feel great, so I'm going to go for a walk and I'm going to climb the stairs and I'm going to do the laundry. Oh my goodness, no. Even if you feel great, awesome, you feel great, and now you can rest and still feel great while you're resting. You need to rest. Even if somebody has a vaginal birth, they need to rest after giving birth. Birth, regardless of how it happens, is a very, very big physical event. And so it's very important that they allow their body to rest. Now, talking specifically about cesarean birth, this is also major abdominal surgery, and you're caring for a little person 24/7. You have to lift that person up, and you have to feed that person, whether you're feeding them from your body or from a bottle. And all of that requires more physical demand from your body than any other time when you'd have major surgery, when you'd truly be able to rest. So please, please, please don't do only what you need to. Do only what is most minimal. That might mean asking for help from family and friends. Oftentimes they want to help and they don't know how to help. So make sure you call in that support. This is a good time to practice being assertive about what your needs are. If you have a partner there with you, make sure you share openly in terms of what you need from your partner. Really, really important for everyone to kind of make sure that the person who's healing from birth has that opportunity to truly rest. So for discomfort of digestive issues, a stool softener can be really important. Again, that narcotic pain relief can cause constipation, discomfort at the incision site or in the abdominal muscles, in the lower back. Prescription pain relief can help with that. When you are bending, when you're lifting, when you're moving, when you're feeding your baby, it is so important to use functional breath and core engagement. Functional breath means, that's the term that I like to use for diaphragmatic breathing, which is breath that actually ties into correlating your increases in pressure in your abdomen from the increased breath with pelvic floor function. I can't emphasize enough the importance of getting help or support from a pelvic floor PT. They are often covered by insurance. There are also pelvic floor PTs that you can pay for out of pocket. Seeing a pelvic floor PT in pregnancy will help to prepare you for birth, and then you already have a relationship with them that you can then kind of take with you into that postpartum. Also, pelvic floor PTs go over core breathing, diaphragmatic breathing, functional breathing, and they give you really great practice for that type of breath that is going to be really important for functional movement. In a few of the webinars that I have, we've gone over diaphragmatic breathing. I also have a diaphragmatic breathing audio track available. If anybody is interested in that, you can send me an email and let me know if you'd like me to send that to you, and you can kind of practice that diaphragmatic breathing. So walking and moving is really important, going to the bathroom, emptying your bladder, but we don't want to be doing any sort of exercise movement. We don't want to be going for walks around the block. We don't want to be walking on a treadmill, nothing like that. Not until your bleeding completely stops and you get the okay from your provider. And even then, I can't emphasize enough, going to your 6-week appointment and being told, okay, you're in the clear for exercise, does not mean that you go start running 5 miles a day. No, that just simply means everything looks like it's healing well, but your body still requires more time for true healing. So please go easy. And again, having the support of a pelvic floor PT can be so important for that kind of shift into getting back to what your quote unquote normal life might be after healing from birth. Don't lift anything heavier than your baby. This is a good rule of thumb, no matter how somebody's given birth. Until the bleeding has totally stopped, don't lift anything heavier than your baby. And anytime you are lifting, make sure you are exhaling. So you go to lift your baby up, you inhale, and then as you lift your baby, you exhale. That ties into that functional breath that we were talking about. If you have to cough or sneeze, that can cause tremendous discomfort in the incision site. So having a pillow close by that you can kind of hug and press against the incision site as you cough or sneeze is really important. Also, when you are feeding your baby, if you're nursing your baby, using positions that do not put excessive pressure on the abdomen can be helpful, like a football hold, for example, or a side lying position. In terms of keeping the incision clean, you do want to wash it with mild soap and water once a day or every 2 days based on your provider's recommendation. They will give you specific instructions for supporting the healing of your incision site. The incision can get itchy as it begins to heal, and that's a good sign. It's a sign of healing. Your vaginal bleeding will gradually diminish. It'll turn into more of a yellowish discharge, but there should not be active bleeding at all happening from the incision site. When you have given birth by cesarean, we don't want that incision site being submerged in water. So taking a shower is fine after the first couple days, but we want to make sure that we are avoiding baths until that area is completely healed, which generally takes about 2 weeks or so. So I would say avoid baths for about 3 weeks to make sure that you're fully in the clear with that healing. If you are having complications at the incision site, here are some red flags to look out for. Warmth, redness, swelling, or oozing at the incision site. Call the provider immediately. If your pain gets worse or you have a sudden onset of pain, call your provider. If you have a fever, even if your incision looks totally fine, call your provider. If there's a vaginal discharge that is foul smelling, call your provider. Pain or burning when you're going to the bathroom, call your provider. The urge to pee frequently, but not a lot of pee coming out, call the provider. If you have urine that is dark or very minimal or bloody, call your provider. If there is anything happening that you're like, I'm not sure if this is normal, call your provider. Even if it does not fall into this list that I just gave you, call your provider. That is what they are there for. And again, with such, no other way to put it, but such shitty postpartum care in this country, It is very crucial that we be our own best advocates. So if anything does not feel right to you, call your provider. And please keep calling, keep reaching out until your voice is heard. If that means getting your partner or a support person to call for you, make sure that happens. We need to be our own best advocates because postpartum care is just not adequate in this country. One thing that I want to mention that I think is often, again, overlooked is the need for scar mobilization. This is something, again, that pelvic floor physical therapists would go over with you. This can be done around 6 to 8 weeks postpartum, and it can begin with just kind of desensitizing the area a little bit and then move into some scar massage. I have a video of this on my Instagram account. You can also follow pelvic floor PTs that have videos of this on their Instagram account. I've reposted Instagram account posts that are all about cesarean scar massage. So definitely check those out. If you're looking to follow me on Instagram, it's Blossoming Belly's Birth. You can find cesarean scar massage videos there, as well as some, of the other things that I share. But scar massage is really important. And I've never had a client whose provider has talked with them about scar massage. Never had somebody whose midwife or OB has mentioned scar massage. And it's so important because as that incision site heals, the scar can actually wind up creating adhesions to other tissue in the nearby area, which can wind up leading to discomfort in the abdomen, urinary tract infections, low back pain, hip pain, imbalance in the uterus. We can wind up with all sorts of issues. Eventually, it could even lead to things like incontinence and prolapse. We can wind up with all sorts of issues if the scar tissue adheres to the tissue around it. Scar massage will help to break up any of those adhesions and allow the area, the scar itself, to heal solely in the uterus and prevent any sort of pulling or tugging that could wind up leading to further discomfort and even issues down the road. All right, so a couple other things to consider. Healing from a cesarean requires time, support, patience, and encouragement from the postpartum support and the person recovering. Give yourself that time. And if you're a support person on here, make sure your partner or your client, whoever it is, knows that they deserve that time to heal and rest. Don't hesitate to ask for help when needed. Oftentimes, we hope that people around us will know how to help us. We need to make sure we request that help. People experience varying levels of discomfort after a cesarean, so be aware of those red flags. If anything seems off to you, call your provider, but also recognize that everyone's experience is different. If you have somebody in your life that was like, oh yeah, I had a cesarean, it was no problem. I was like, walking around the block 1 week postpartum. Okay, not ideal, but that's their experience, not yours. Everyone experiences things differently. So again, give your body that grace to heal as it needs to and separate your own experience from someone else's. No matter how you feel, how good you feel, rest is so important. Can't emphasize that enough. Here are a few reminders, and these come from Aviva Jill Rome, who is an obstetrician, a midwife, an herbalist, and she has written several books, one of which is called Natural Health After Birth, The Complete Guide to Postpartum Wellness. So these reminders just come directly from her. Remember, pain in the abdomen, back, and shoulders is common due to that gas and that bloating that we talked about. It passes on its own, generally within about 24 hours. It's a very common part of post-surgery healing, but it's very uncomfortable. Soreness at the incision site can last for several weeks. There could also be weeping from the incision site, but if there's any sort of pussy discharge, if it has any sort of foul odor, that has any sort of color to it, call your care provider. To prevent abscess or infection, make sure the area is kept clean and dry. Allow good air circulation and sunlight to reach the belly for at least 20 minutes a day. And again, your nurse will go over with you how to change that bandage on a daily basis so that you can make sure that you're keeping the area clean and allowing that healing process to happen. Again, as we mentioned, it's preferable to wait to take a bath until the incision heals, which is generally about 2 weeks after birth. So I like to say wait about 3 weeks to take a bath just to make sure that that healing has totally happened. Rest is so important. Motion and flexibility are often impeded after major surgery. So go easy with your body. That is the moral of the story. Go easy with your body and make sure you are connecting your breath to when you are lifting so that you are not creating extra abdominal pressure that can wind up delaying the healing process or creating more discomfort. All right, here's our takeaway for today. Understanding the process of cesarean birth sets the foundation for a healthy emotional and physical experience of childbirth. And that's the goal, to come out of the experience feeling like, okay, That was awesome. I did something totally amazing. I just brought a baby into the world. That's incredible. During surgical birth, people have more options available to them than they typically realize. Communicate with your providers, but do that prenatally so that you make sure that their expectations are clear to you, your expectations are clear to them, and that you've made requests of anything that's important to you. Knowing what that healing process looks like and being equipped to provide the time and the space for the body to recover is so important. And this is important for your long-term physical and mental well-being. So please, 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 again, honor your body. Make sure that you give yourself the time, the rest, the patience that you need in order to heal properly, physically, and emotionally from your birth experience. So here's where you can find me on Instagram, TikTok, and Facebook if you are interested in following along. And again, you could also totally check out those Instagram accounts that I mentioned, Dr. Natalie Elphinstone, as well as some physical therapy accounts that I think are great, like Dr. Just is really awesome. Vagina Rehab Doctor is great too. They post a lot of great stuff related to pregnancy, birth, and postpartum. So we have a couple questions in the chat that I just want to get to before we sign off today. So let's see what we have here. Some of these we've already answered. How late is too late to start scar massage? Oh my gosh, that's such a good question. It's never too late. Somebody could be 6 years postpartum and start scar massage. It is ideal to start it around 6 to 8 weeks postpartum so that we prevent any adhesions from forming in the first place or break them up early on. But, and they wrote yay in the chat, but it's never too late. So even if somebody gave birth 10 years ago, it's never too late to start scar massage. It might take more effort, it might take more consistency, but never ever too late to start scar massage. So that's something that you could do or your clients could do no matter how long ago they gave birth. And it's something that, so I'm a doula, and when I do postpartum visits with clients who've had cesarean birth, it's one of the things that I go over in the postpartum visit. Not physically doing it with them, but describing it to them and giving them resources for it. Because again, it's one of those things that providers don't talk about. And I think it's really, really, really important for people to have that understanding of how impactful cesarean scar massage can be. Cool. Thank you so much. This has been really great. So you guys will be able to find this recording on the website if you want to watch it again and again or share it with clients. I will also send it out in an email to you so you'll be able to access it that way if you'd prefer. Next month, as I mentioned, we'll be talking all about communication and advocacy during prenatal care. That's a $15 webinar with 1 contact hour through ICEA. So for anyone here who's a birth professional and you want some contact hours, you can join me for that. If you're an expecting parent, that webinar would also be awesome for you too. It's about communication and advocacy during prenatal care. And then I'm not sure what we have coming up for February. I have to kind of see. I have a few ideas floating around, so we'll see. But you can stay up to date by following along on Instagram. And if you want to just check the website periodically, you'll see what I have coming up there too. So thank you all so much for joining me today. Keep an eye out for the email. It'll come up probably either later today or tomorrow. I'll send it out. And yeah, have a wonderful day. Thank you so much, everybody. Bye.
Thank you.
Oh, you're welcome. Bye.